TopMedTalk.
Well, hello and welcome to TopMedTalk. It's Desiree Chappell, and we are here at the Society of Critical Care Medicine in Orlando, Florida. We're so excited to be here. This is the first time we've ever made it to this meeting as TopMedTalk. Now, today I'm joined by my co-host, former editor-in-chief, founding editor of TopMedTalk, Monty Mythen.
You had to think about that one, didn't you?
I did. I was like, oh, what are we calling him these days?
Monty's fine. It's good to be back, Desiree. You let me back in because your other co-hosts are elsewhere at the moment.
They are. They're all over the world. But I caught you here in Orlando and excited to be kicking things off talking about critical care medicine, which is actually a little bit outside of our space that we normally are talking about. But we have over the years definitely gotten into critical care.
Which is strange as we reflect on it, because critical care was part of your life early on as a nurse.
Sure. I was a critical care nurse before I was a nurse anesthetist.
How long was that for?
I did it for 3 or 4 years as I worked in the ICU as in different stages.
Is that nursing. Part of becoming a CRNA is one needs to
It
do?
is. Yeah. You have to have at least 1 to 2 years of critical care experience now. You know, I actually worked in a couple different guises within the critical care setting. So as a nurse and a nurse's aide and a secretary and all those different things. So I got to see a lot of different aspects.
So you know the space well. And most of my life was as a my colleagues might argue, most of my life was as a critical care physician in the USA, then back in the UK, and cardiothoracic at one stage, always general ICU, and finishing off more in sort of surgical ICU space. Yeah. So things we're going to be discussing, we understand reasonably well.
Yeah, fairly. I would say fairly well. Even though we have talked a lot over the years about anesthesia. Well, Monty, I'm so excited about our guest here that you were able to catch up with earlier in the day and grab and say
a legend.
Yeah,
critical care
it
medicine.
is a legend of critical care medicine and fluids, the utilization of fluids in our space. And actually a previous guest here on TopMedTalk, a TopMedTalk fan fave, Professor Manu Malbrain. Manu, welcome back to the podcast.
Hi, Desiree, Monty. Fantastic to be here again.
That's right. Well, we were just reminiscing that it's been a while. I think back in the days of a pokey 6 maybe that we did at Duke specifically on fluids.
So, if I may, Manu came to fame, as far as I'm concerned, early on, originally rating to intra-abdominal compartment syndrome, however you're going to describe it to us in a moment. In other words, the downside of pressure rising in the abdominal compartment, the knock-on consequence of that. And then after that, which I think we're going to talk about as well, the International Fluid Academy, which is still going really strong today. I've been lucky enough to attend a few meetings. It is the place to go in the world to discuss fluid management.
Yeah.
Okay. You're giving me too much credit, Monty.
It's all downhill from here.
But it's funny how things go in life. In retrospective, I look at it, why we are sitting here is because when I was a first-year trainee for internal medicine, I received from my supervisor a paper on intra-abdominal pressure monitoring through the bladder. Can you imagine? Never heard about it, so I start reading and then measuring it in patients. And I got my first abstract presented, I think it was at a World Congress in Ottawa in Canada. And then you meet people and the ball starts rolling. And that's exactly why we are sitting here today. Yeah.
Tell us a little bit about your journey, the quick accelerated version of myself and Desiree telling you about a little bit about our life. How did you end up as a critical care physician?
So my father was a doctor. He's a pediatrician. So I was studying Latin and mathematics. I'm the youngest of 6, and my 2 older brothers went for civil engineering. So after finishing high school, took the exam, and I started off engineering. After a year, I decided to switch.
Following your dad's footsteps.
Past that year, but then it's always looking what is best to have a holistic view on the patient. I think internal medicine is good because it keeps you thinking, it keeps you bright in the head. Although I had my name not in favor because I always make a joke of it. I say there was an S up front, a small brain. So I had to check it.
It's a bad brain.
But at least I have a brain in my name. We all have one, but you have to use it. No kidding. So I started off as doing internal medicine, first oncology, which is also wide, but it takes months to see the effects of chemo on the improvement of the CT scan. So then I thought critical care medicine is very quick decision making, and you directly see the impact of what you're doing, if the patient is safe or not. That's basically my background. I'm trained in Belgium, so at the Medical Catholic University in Leuven. And then I got this interest in abdominal pressure whilst I was in my first year of training in internal medicine. And I did my PhD on the same topic. At the time, it was not well studied, it was not well recognized, there was a lack of clinical awareness, and patients were dying left unmonitored and untreated. And from there on, I realized that giving fluids and too much fluids, overzealous crystalloid and saline resuscitation in a patient with an abdominal sepsis leads to intra-abdominal hypertension because of the fluid sequestrating in the second and the third space. You get ileus and so forth. So basically, abdominal hypertension is iatrogenic because of overzealous fluid resuscitation, except for the surgical cases where you have a trauma or a perforated viscus, which are clearly primary surgical. But all the medical reasons, like in severe acute pancreatitis, in patients with sepsis, in patients with burns, for instance, is mainly due to inappropriate fluid administration. And that's why about 15 years ago, we founded the International Fluid Academy.
So you started in measurement of intra-abdominal pressure. Just, I've spent a minute since I've been in critical care. Where are we on that now from like measurement wise?
So because of the lack of awareness, I did the first multi-center studies, and I'm very lucky to have Luciano Gottinoni, good friend. Unfortunately, he died recently, yes. He was the senior author of my two papers that eventually led to the PhD. And around that time was 2004, a little bit later, we founded the Abdominal Compartment Society, which at that time was called the World Society of the Abdominal Compartment Syndrome.
Wow, that's helpful.
Yes. And it was in beautiful Noosa with Michael Sugrue, the guy from the paper that my supervisor gave me to read. So I was able to meet him in person, and we founded this society. There was Mike Cheatham from US. There was Rawi Vaturi from US, Michael Sugrue from Australia, and me, a little guy from Belgium. You only need to be 4 to create a world society.
Oh, okay. Well, no, good to know that.
Been there, seen it, done that.
So all these years have gone by now, and we know, and hopefully we'll get a little bit more into abdominal hypertension and why that is bad, but are we truly measuring?
Yeah. So after the creation of the society, the first task was to write some guidance and consensus paper on the definitions, recommendations for treatment and management. And these have been very highly cited. It was published in Intensive Care Medicine, I think over 1,000 times. So we recognized, okay, there is a need. There is still a knowledge gap, and we need to continue. So we performed more studies, research, surveys on the awareness, the knowledge. We saw it improving a little bit. But now I must say that there is still a gap. And that's why we decided after COVID, the idea was to close down the society. Meanwhile, we had changed the name to the Abdominal Compartment Society because the compartment syndrome is the very end of the spectrum when things go wrong. And I think we wanted to put a focus on prevention earlier on, when the pressures are not that high and not yet creating a compartment syndrome.
People, we probably recognize syndrome, but maybe not thinking back before that, all the madness actually happens.
A syndrome is a yes or no binary, whereas the abdominal hypertension is more graded, a continuum with ongoing organ dysfunction and failure. So after COVID, we said, okay, everyone knows about the syndrome and about abdominal hypertension. Let's call it a day and stop the society. We did a survey, and we found that many colleagues, especially from low middle income countries, said, no, it's too early to retire because there is still a lot of work to be done. So we are now trying to revive the Society 2.0. We are reworking on an updated version of the guidelines, and there is some new evidence and publications coming out, as well as new monitoring tools to allow us to assess the abdominal pressure continuously.
Yeah.
Because normally you can only do it intermittently by clamping the bladder, putting some sterile saline and connecting it to a pressure transducer like you would measure central venous pressure, but now in the bladder.
In the critical care, that was not something that we traditionally did.
Yes, I was
when
going to say,
there.
if there's some young critical care doctors, nurses listening at the moment who might not be completely familiar with what we're discussing, how does it happen? How does it manifest itself?
Yes,
This is aside from, I think if someone's had abdominal trauma, they kind of understand that the swelling of the contents of the abdomen might be a problem. But what about the patient who's had another form of surgery or a different form of sepsis and they're on the ICU and they're wondering what's going on?
Yeah, the idea behind the guidelines is to provide some guidance, and we have identified like 4 major groups of patients. So basically, it's about risk factors. Who are the patients that have the most risk to develop intra-abdominal hypertension? Those can be related to the abdominal wall and the compliance of the abdominal wall, which we see decreases in patients with obesity, for instance, in patients with fluid accumulation syndrome, in patients with circular eschars after burn injury. But there are also differences between genders. If you have a man with a six-pack, the compliance will be poor because of the stiffness. If you have a woman, for instance, who gave childbirth before, there has been a stretch on the fascia, and that compliance will be higher. So it's kind of protective mechanism. So first, the abdominal wall compliance. Second, all the things associated with increases in intraluminal content. This could be gastric distension, this could be ileus, this could be stool, and so forth. The third risk factor is related to increases in free abdominal fluid, like you see with ascites formation, like an abscess or bleeding. And the final is this iatrogenic cause related to resuscitation in patients with sepsis, capillary leak, or in trauma patients who receive a lot of transfusions, the acidosis, hypothermia, coagulopathy, the deadly vicious cycle that leads to ongoing resuscitation. And of course, all these surgical indications after major abdominal surgery, major vascular surgery, ruptured aneurysm. So there are a lot of reasons. And the idea, if there are 2 or more risk factors, it's wise to obtain a baseline abdominal pressure measurement, which can easily be done. Patient in the supine position, you zero at the mid-axillary line where it crosses the iliac crest, you clamp the urinary bladder, you instill 10, 20 cc's of sterile fluid, and you have your transducer. And this is your baseline measurement at the end of expiration. Of course, the patient should be relaxed and not using the abdominal muscles like you see in forced expiration with COPD patients. So basically, it's very easy, but for some reason, it's a bit cumbersome, and there is the risk of CAR-T, and nurses don't like to mess around with Foley catheters and urine and clamping and instilling. So a closed automatic technique would be helpful in a plug-and-play fashion to get it as the 6th vital sign, which I believe it is, because without abdominal pressure, you can't support the other organs well.
And the person who hasn't been very aware of it at the bedside, they would notice a swollen abdomen, would they? And
clinically,
or not necessarily. Like? And when they examined it, would it be tense or not tense? So there's a lot. It's
a good point. Unless you're a surgeon, which I know you're not, you're not able to measure intra-abdominal pressure just on clinical estimation. Surgeons, they claim they can by putting one hand or two hands and assessing the tenderness. But studies have shown that the predictive value is very
So you really
poor.
need to measure it.
Yeah, you need to measure the pressure, because even in an abdomen that is not distended, there can be a poor compliance of the abdominal wall, or there can be a poor chest wall compliance, which also impacts on intra-abdominal pressures.
Yeah, but like, as a nurse at the bedside, and say we're not monitoring abdominal pressures, like full disclosure, that was not something that we did in our ICU. Of course, that was 20 years ago. I haven't seen it in the ICUs that I've been in. It's so clinically, what does that look like for, other than, the physicality of the abdomen, but I mean, vital signs,
Mm.
is it like after I've given so much fluid, or what are some of the things
Yeah.
that nurses can be looking for?
Well, the nice thing about it,
this?
I'm an internal medicine physician. It has basically an impact on all organ functions, not only those concealed within the abdominal cavity, but also far outside. So it can increase intracranial pressure. There's been studies looking at combined traumatic brain injury, abdominal injury, where you have to treat the abdomen to solve intracranial hypertension. For instance, it has an impact on filling pressures. Your CVP will be erroneously increased because we zero against atmosphere. We don't zero against pleural pressure, which we should do. So looking at transmural filling pressures could be helpful. Ventilation, you will have very high peak pressures, high plateau pressures, low driving pressures. So the patient will be difficult to ventilate in a lung protective fashion. So you need higher opening pressures, higher PEEP to keep the lung open. So it has an impact on everything we do, but I'm biased. If I don't know the intra-abdominal pressure, I can't treat my patient properly. I cannot assess barometric preload. I cannot assess ICP. I cannot assess fluid responsiveness because due to the increase in intrathoracic pressure, PPV, SVV will be increased. So our thresholds for fluid responsiveness may not be 15%, but 25%. Same for the passive leg raising. If your abdomen is distended, there will be no autotransfusion, so you have a negative passive leg raising. Same for the kidneys. The back pressure at the venous side is more important than the cardiac output. Like it's not only forward failure, it's also backward failure. And renal perfusion pressure can be calculated by the mean arterial pressure minus the intra-abdominal pressure minus the CVP minus the mean alveolar pressure if the patient is on positive pressure ventilation. So you sum that up and you may realize that renal perfusion pressure is maybe 20 millimeters of mercury, which is too little. So the kidney is usually the first organ that starts failing. So like the canary in the coal mine for intra-abdominal hypertension. We adapt enteral nutrition based on intra-abdominal pressure. If the pressure is 15, we halve. If it's 20, we stop enteral nutrition. We have a stool protocol. If the pressure increases, we give enemas, we give prokinetics. So there is a whole way of treating the patient based on these four levels, like improving the compliance, reducing intraluminal content, intra-abdominal free fluid, and then the perfusion and the general fluid management.
So you've got everyone's attention now. They want to learn more about this, but relatively quickly. You said you'd publish some guidelines?
Yes, the last update was 2013. So we just published a survey on the consensus definitions, which was out 2024. And we are working on the revision of the guidelines. But everything is freely accessible under the free open access medical education at the members portal of the Abdominal Compartment Society.
Abdominal Compartment Society. What's the website? The www.
WSACS, WSACS.org. Awesome. We kept the name because people know the WSACS, but now it's the World Society of the Abdominal Compartment.
That's good.
Stories.
Yeah, well, we'll put that in the show notes. So if people want more.
We have the website and we have also the members portal that contains all the resources, like a full book that can be freely downloaded, lectures, videos, the guidelines, the research, everything is there.
Fantastic.
And then if people want to learn more, they could come to an IFAD meeting.
Yeah, so tell us more about IFAD.
IFAD is the International Fluid Academy, which was created about 15 years ago, 2010-11. And at that time, that was before the big fluid trial, so before the success and the chest trial, where it was perfectly safe to give balanced crystalloids like plasmolite, Ringer's lactate, but also balanced starches like the volulite. So we decided with the Medical Pharmaceutical Committee to choose for balanced solutions, colloids, starches, crystalloids. And we wanted to inform the doctors of the hospital, so we invited some colleagues. I think you were at the first meeting in Antwerp. Monty was there, so we invited Monty and usual suspects on fluids, Dilip Lobo and Julia Wendon was there, Raziel Perel. And we had a full day program. So we said, it's not just about informing the doctors in the evening with one lecture, but it's a full day, so we should give it a name. So we had all these names like Intergalactic Fluid Academy, and then we said International Fluid Academy. International,
Keep
it's
it,
more.
keep it small.
Yeah, but
You're not
international is more than national.
Yeah.
And
But
an
not
academy,
galactic.
academy gives you a credibility
Yeah.
because it's like a university.
Hmm.
But then we saw after the first meeting, there were 250 delegates from all over Europe, and it was growing. We went from 1 day to 3 days with over 500 delegates with pre-courses on ultrasound, fluid stewardship, sepsis stewardship, nutrition stewardship, antibiotic stewardship, as well as hemodynamic simulation sessions. So we realized this is serious. It's not just a gimmick or a joke. This is really a knowledge gap that we can fill. Also, we adhere to the free open access medical education principle. So all the videos from all the International Fluid Academy days, we call it IFAD. And now we have pop-up meetings, which we call IFAD Mini, all over the globe. So we've been in Africa, in South America, in Philippines, Malaysia, and Indonesia, Bali, beautiful. So it seems like
Texas, America, United States of America.
United States, not yet. No, I don't know why. We organized some webinars due to Hurricane Helen that resulted in a shortage. So the webinar was on rationalizing IV fluids to limit the fluid intake, which was a good thing.
Restricting though, right?
Yes, restricting, it's withholding, it's withdrawing. So you can have different things, and it's de-escalation, sometimes de-resuscitation. So this is how the Fluid Academy started. It was also a project on social media. So Society has about 18,000 followers. When we do the meetings, it's 35 plus million
And you
impressions.
were doing virtual meetings and bringing people in before COVID to IFAD.
Before COVID, everything was physical, in person.
Oh, is that right? We did
with a big social media.
But with a big social media, I guess that's what I'm thinking.
Yes, exactly. By inviting native English social media team.
Yeah.
I think at some point we had 25 people covering Twitter, LinkedIn, Facebook, Instagram, podcasts, blogging.
Yeah. It's very effective.
You name it.
Yeah.
And it resulted in a kind of a global brand. Everyone knows about the International Fluid Academy and the free open access education it stands for. So we just launched the Basic Fluid Champion course, which is a 6-module course on fluid homeostasis, the basic properties of fluids, fluids for resuscitation, maintenance, replacement, and fluid accumulation syndrome. After the course, you get your EACCME, and it's free.
Yeah.
It's free for every student to attend.
How many hours does it take to do the full course?
So the video by itself is about 7 hours, and then you have the multiple choice questions and the theoretical part that you need to read. So altogether, it's probably 12 hours.
Oh, wow. And is it specifically just around medical ICU and critical care?
No,
intraoperative, like surgical, perioperative?
Not at all. The basic course is for doctors, nurses, pharmacists, dietitians. So it's really the basic principles. And what we are looking for is we help hospitals on the path to excellence to become a center of excellence on fluid stewardship. And in order to reach that, they should assemble a team with one chair of the core fluid team, doctors, nurses, pharmacists, dietitian, all becoming a fluid champion.
Yeah.
Once they follow the online course as a team, they should participate in a physical meeting where we have hands-on demonstration, like we do a passive leg raise with a non-invasive monitoring tool, could be the ClearSight or the Starling monitor. We do a bioelectrical impedance analysis to show body fluid composition. We can do a Vexus score to show them how do you assess fluid accumulation. And at the end of the day, there is an exam. And if a team of fluid champions of one hospital participates, they get the silver label Center of Excellence. But then all the hard work starts with the pharmacy, looking at the issuing, the consumption of fluids, looking at the knowledge test, the medical audit, and that is the whole program. It's kind of quality improvement, but it's also cost effective. So it's kind of value-based healthcare.
Nice. That's
So
great.
why no progression in the USA? Because there's no lack of need. I think, Desiree, you're a quality person in the USA. Is there fluid variability?
I just was giving some lectures the other day, and I mean, the question is crystal or colloid? How much is too much? How much is too little? What does fluid restriction mean? Why are we in the place that we are? I mean, this is perioperatively specifically, but in the hospitals, there's a huge need. I mean, to balance some of the things that we've gone through, like fluid shortages, what we are doing in different areas of the hospital. So yeah, there's I still think a huge need out there. There's just so much variability. I think it's the big thing.
Exactly. And you need to limit the variability. You need to protocolize something, but allow personalized care, individualized care, so that the targets, the goals, the triggers, and the safety limits are not uniform, but are dynamic during the course of the patient. That's why I know Monty was on the paper calling it SOSD.
And on the paper calling it with you,
salvage,
Rose,
optimization, stabilization, de-escalation, but SOSD is difficult to pronounce. So we asked Twitter, X now, what do you prefer, SOSD or Rose? And I can tell you that the majority of respondents prefer the rose because it's like the flower. You water it and it blossoms with the fluid resuscitation. And then at the end, it may dry, but it's not a dead patient, of course. So it's like a visualization of the dynamic phases of fluid therapy with resuscitation, optimization, stabilization, and evacuation, which is more than de-escalation, because de-escalation is just withholding, withdrawing. Evacuation is giving diuretics or CVVH with ultrafiltration to remove the excess of fluids. It's more like an active treatment.
This is fascinating. I can't wait. I would love to have another conversation with you later in the year after the guidelines have come out for the abdominal compartment, not syndrome, but management society, and around fluids for sure. But we can definitely find you. The IFAD is all over social media. So just type IFA, right? International Fluid Academy, and into any of your social media platforms, right? Are you there everywhere, even on TikTok? You doing any TikTok videos?
No, TikTok, yes, no.
I think there might be a new space for you.
Yeah, maybe. We'll have to check with the society manager, because in order to professionalize, we now have our society manager to deal with the social media, and it's going very well. So the members portal is almost 6,000 members from all over the globe. Yeah,
and it's all open access, and you can.
That's the philosophy, but of course, giving everything for free is not a good sustainable business model. So we are now looking for partnerships with industry to help us via unrestricted educational grants to support our endeavors to provide this open access medical education, which is not easy, but we are getting there so that we can continue to provide everything for free. Just as an example, we published the book on the rational use of IV fluids with Springer, 600 pages. The book is open access. So you can go to the Springer site and download a 600-page PDF.
Wow.
Guess how many times it's been downloaded? 1,320,000 times since last year it was published.
Phenomenal. Yeah, that's
which tells me two things. One, if it's for free, people like it, of course. But two, that there is a gap and that people want to learn and understand more about fluid stewardship.
Oh, absolutely. It really doesn't surprise me, because I think there's so much knowledge to be shared out there, and in spaces just like this. So thank you for all that you're doing in that space. And we definitely want to direct everybody to there. And if you're interested in supporting IFA, please, if you're one of our industry listening, that's another, and that's right. we're pointing fingers all over the place here. And
everyone's clapping and cheering and saying, yes, we will.
We got
you. Yes, we can.
We got you. Phenomenal work. Thank you so much, Manu.
A pleasure.
All right. Well,
see you
virtually next time.
See you virtually in the members portal.
Yeah, there you go. Absolutely. We'll check it out. Monty, thanks for joining us on this one.
Desiree, it's great to be here. Now, before we finish completely, we're going to do a follow-up recording shortly.
We are.
Because Professor Malbrain has actually lived some of the things that he was telling us about, and he's very generously agreed to share some of his personal experiences as a patient.
Yeah. So we just finished part 1. So part 2
coming shortly.
Coming shortly with Professor Malbrain.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe. Check us out on YouTube. And of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.